Good evening. Let us all start tonight's event with a prayer. Bismillahirrahmanirrahim. We offer to you our meeting today. We pray that through your divine guidance, we would learn how to listen attentively to the inputs of our speakers. May we appreciate her efforts in imparting her knowledge to us. May we participate actively in the discussions and activities so we could learn more while having fun. May we value each other's contributions as building block towards harmony and peace. Grant us that we interact with one another. We recognize the fact that our learning activities should be accomplished for your greater glory. Grant that we recognize you in each of us as we leave for home. We pray that you keep us safe from harm and illnesses, and we will be able to apply correctly what we have learned today. All this we ask in God's name. Amen. So good evening once again, dear colleagues and friends. I am Dr. Fat Matthew, and I will be your host and moderator for this evening's event. So this event for tonight is in partnership with Novo Nordisk. This is our lecture 2 for the special edition of the PSD Select 2. Our topic is diabetes and the alpha cell. So the pandemic caused by the COVID-19 virus has put us into freeze, surprise, and extreme anxiety. It had infected millions of people around the globe and killed a lot. Mostly affected are our diabetic patients, since they are at higher risk of contracting severe complications caused by the infection. So the Philippine Society of Diabetology's Board of Directors has taken this opportunity to enhance our knowledge in pursuit of excellence in diabetology during this period. In line with this, we are having this PSD Select lecture series and postgrad course. This is a series of virtual lectures, 1 hour each event, to keep our alumni abreast of the latest updates in diabetes. Our objectives for this evening's meeting is to appreciate the role of alpha cell in metabolic homeostasis, to discuss the role of alpha cell in the pathogenesis of diabetes, and to discuss interesting issues and concerns after affecting individuals with diabetes. The program will run as follows. First, we will have the kwentuhan with our Kuya Elwin. Then, we have a lecture from Novo Nordisk by our very own Dr. Marcelo Lim, who will talk about 100 years of insulin innovation and the clinical impact of the new generation insulin. Then, we will have a discussion on alpha cell dysfunction in type 1 diabetes by our very own again, Dr. Nines P. Bautista. Then please reserve all your questions for the open forum. You can type them in the chat box. Reminder, please write your names in the chat box because that will serve as your attendance to this lecture series. So let us now begin with the kwentuhan tayo with Kuya Elwin. Let us all welcome our President of the Philippine Society of Diabetologists, Kuya Elwin. Magandang gabi, Kuya.
Good evening. Kamusta na kayong lahat? Ikaw ba Fatma nabakunahan na?
Nabakunahan na, Kuya.
Very good.
Naunsiyame, nung unang araw, tumaas ang BP ko, hindi natuloy. Pero nabakunahan din ako nung kasunod na araw.
Very good. Very good. Ako rin, tapos na. Nataon sa ang ano ko, ang second dose holiday. Walang may gustong pumuntang mambabakuna sa holiday. Kaya minog nilang 4 or 5 days. Pero matatapos din naman. Naging April 6 ako yung aking second dose. After second dose, maghihintay ako ng 2 weeks. Kasi after 2 weeks, meron ng ginagawa sa St. Luke's na neutralizing antibody. Yun, baka pwede kong magpagawa, less than 2,000 pesos daw, yun
Iba
nasabi.
yun kuya sa usual na antibody test na
Ay,
ginagawa
iba.
natin. Iba.
Iba yun.
Neutralizing, no?
Neutralizing
Antibody.
antibody. Titignan kung talagang nag-produce ka ng enough antibody na may panglaban ka na kung may darating na viruses. Kung may viruses na darating. Pero alisto kayo kasi ngayon may bagong test sa Amerika. Hindi na neutralizing antibody tinetest nila, kundi yung T memory cell ang tinetest nila.
Wow.
Kasi pwedeng wala kang antibody kasi wala ka namang infection eh. Pero importante, may naka-ready kang T memory cells. Meron na silang pang-test noon. Hindi ko lang alam kung magkano at kung makakarating sa atin. Pero yun yung cutting edge sa diagnosis ng meron ka ng antibody against COVID-19. Pero, ate, babalik na ako sa Alpha-Cell Meron pa akong
Okay.
20
Sige.
minutes para pagkwentuhan natin yung Alpha-Cell. Yung unang mga episodes natin, pinag-usapan natin yung history ng pancreas, pati pati yung embryology ng pancreas. Tapos tayo dun sa histologic development of the islets of Langerhans. Kaya napag-usapan natin kung bakit yung yung islets of Langerhans ang ganda-ganda ng arrangement sa rat Ito sa rat kaya ang ganda ng arrangement no? Pero sa humans ba't hindi maganda yung arrangement? Kasi sa humans pala, napag-usapan natin na sa development, very, very well arranged sila. Parang isang sheet ng alpha cell, nasa gitna yung beta cell, marami. Pero yung sheet na yon na parang kumot, nakakrumple yan into a ball, nakakala mo walang arrangement. Pero bawat isang alpha cell ay may katabing beta cell. They are juxtaposed. Yan ang term na ginagamit ng mga histology. At yan inintroduce sa atin ni Dr. Ernie Ang ng ating first lecture on the alpha cell. Bawat isang beta cell o alpha cell may katabing, importanteng may katabing beta cell yan. At later, pinag-usapan din natin kung bakit. Kasi meron silang paracrine effect. Ibig sabihin, paracrine, yung substance na ginagawa ng isang cell, ang effect dun sa katabi niyang cell. Paracrine effect yun. Pagka ang effect noon sa sarili, autocrine ang tawag. Pero kung ang effect naman sa malayong cell, tawag endocrine effect. Endocrine effect. Ang pag-usapan natin ngayon, pagkwentuhan na nga natin ngayon, yun lang konti yung production ng glucagon. Production ng glucagon at saka yung nangyayari sa type 2 diabetes. Konti lang. Basically, pag-usapan yun ni Dr. Nines yan. Yung malaking protein ang pinanggagalingan ng glucagon. Malaking protein yan. Ang tawag pro-glucagon. At ang pro-glucagon na i-encode ng genes na nakatago sa chromosome number 2 sa humans. Sa rats at saka sa ibang animals, ibang chromosomes ang location niya. Pero sa humans, lahat tayo naman humans, nasa chromosome number 2. So it's a big. Kaya pag nagkaroon ka ng abnormality sa chromosome number 2, baka hindi ka gagawa ng pro-glucagon. Hindi glucagon pro-glucagon muna kasi mas malaking protein ang pro-glucagon. It's a big protein. Magtatagal tayo dito sa slide na to. Okay lang sa inyo Kung may tanong kayo, i-type mo sa chat box para mababasa ni Madam Moderator yung inyong mga tanong. Ngayon, ito yung pro-glucagon sa itaas. Mahabang protein yan. Nakalimutan ko kung ilang amino acids yan. Ilang hundreds ng amino acids yan. Pero yan ang ginagawa ng mga cells na destined to make glucagon and glucagon-like peptide. Yan yung alpha cells na nasa pancreatic islets of ang Langerhans. At yan naman nasa iba pang mga cells. Nasa L cells, K cells. Meron ding cells na nandoon sa loob ng naglalay ng brain na gumagawa din ng pro-glucagon. Mahabang protein yan. No? At yung mahabang protein na yan, pwedeng ma-identify yung iba't ibang parts nila. Iba't ibang parts ng pro-glucagon. Halimbawa, may isang part yan, ang tawag glycentine-related pancreatic peptide. Ito yung dark green na una. Pagkatapos nun, yung isang protein na tinatawag na glucagon, pagka naputol yan dyan sa portions na yan, magiging glucagon yan. No? Pero isang mahabang peptide yan. Ha? Pag dito naman ang katabi niya, yung intervening peptide 1. Pagkatapos doon, nakadikit siya sa glucagon-like polypeptide 1, GLP-1, o yung famous na molecule na ginagamit natin ngayon para sa diabetes at sa obesity, o GLP-1. Pagkatapos noon, meron naman nakadikit sa kanyang peptide, another intervening peptide 2. At sa dulo, nandun yung isa pang peptide, yung GLP-2. May iba din function yung GLP-2 eh. Kala nyo GLP-1 lang, may GLP. Baka nga may iba pang peptide siya na kasunod eh. Kasi mahabang molecule yan eh. Pero ito yung peptide na very important kasi depende kung saan siya maputol. No? Yun ang ipoproduce ng cell. Kung nasa alpha cell, no, ang pumuputol niyan na enzyme, ang tawag convertase enzyme. Convertase, kino-convert niya yung isang malaking protein into smaller peptides, kaya convertase. Maraming klaseng convertase eh. Sa alpha cell, ang pangalan ng convertase pro-hormone convertase 2. Yun, pro-hormone convertase number 2. Yan ang dominant na pro-hormone convertase sa alpha cell. Pagka nagpunta ka sa ibang mga cells outside the pancreas, no? Meron yung mga cells naman nila ang dominant na pre-hormone convertase number 1 at saka number 3. Iba yung convertase enzyme na predominant sa ibang cells. Kaya depende kung alin ang dominant na pro-hormone convertase, yun ang ma-determine kung saan mapuputol-putol itong mahabang pro-hormone or pro-glucagon. Pro-glucagon. O, nagkakaintindihan pa tayo dito ha. Hindi pa tayo nagkakahiwalay dito ha. Sige. Pupunta tayo ngayon sa alpha cell na merong dominant na pro-hormone convertase number 2. Pagka yan ang predominant na hormone, mapuputol-putol yung mahabang pro-glucagon into glucagon, glycentine-like pancreatic peptide na hindi naman daw gaano active, kamukha ng intervening peptide 1, hindi din gaano active. At saka may naiiwan pang major pro-glucagon fragment GLP-1, GLP-2 na naiiwan doon sa loob ng cell. Pero ang major production, no, dito sa alpha cell yung glucagon. Glucagon ang major na napoproduce. Ngayon, kung pumunta ka naman doon sa ibang cells outside the islet of Langerhans, no, dahil sa ang dominant na pre-hormone convertase number 1 at saka number 3, napuputol siya at different places. Ang ginagawa niya predominantly is GLP-1. Meron din siyang GLP-2, yung intervening polypeptide, yan, humihiwalay yan pero appears to be inactive. yung glucagon hindi hinihiwalay, no, hindi dinidivorce ng isang peptide na intervening peptide number 1. At pagka hindi humiwalay yan sa glucagon, hindi sila naputol, ibang hormone ang tawag diyan, oxyntomodulin, which is another active enzyme. Napaka-importante niyan sa satiety, suppression of appetite, at saka sa treatment of obesity. Meron ng, ayoko i-preempt yung mga ile-lecture ni Dr. Ang, ha? Pero nandun sa parting yun, magagamit yung oxyntomodulin. Meron pa ibang mga ano yan eh. May iba pang mga products like glycentine. Ang glycentine daw, sa ibang mga animals nag-stimulate ng production ng gastric secretion. Pero sa humans, may mga studies naman nagsasabi na hindi naman daw. Kaya sinasabing inactive enzyme daw, inactive protein daw yan sa humans. Pero marami pang pag-aaralan. Marami pa tayong matututuhan. Marami pang nire-research ngayon dito sa area ng production ng iba't ibang hormones. Yung iba dyan tinatawag na enteroglucagons. Iba't ibang mga hormones yan na pinoproduce ng iba't ibang cells, no, na gumagawa ng predominantly pro-glucagon. Na-digest niyo ba yun? Naintindihan niyo ba yung portion na yun? No? Kasi importante yan eh. No? Ito na tayo sa kung ano nangyayari sa normal pagka ang blood sugar tumataas at nangyayari pagka ang blood sugar bumababa. Pag may type 2 diabetes at saka pagka walang type 2 diabetes. O ito pagka may tumaas na blood sugar sa isang normal individual, i-stimulate niya yung beta cell para gumawa ng insulin. The insulin will go up. At yung insulin na yon, no, ang mag-i-inhibit ng alpha cell to stop making glucagon. Glucagon, alam niyo lahat na nagpapataas ng blood sugar. No? Pero, huwag niyo kakalimutan na ang mataas na blood sugar meron ding indirect effect sa alpha cell. It can be tawag dito, it can be neural indirect effect or it can be molecular indirect effect. Pero ang nananaig talaga dyan, yung pagtaas ng insulin. Yun ang nag-i-inhibit sa alpha cell sa paggawa ng glucagon. Kaya sa normal individual, babagsak ang glucagon production pag mataas ang blood sugar, especially after eating. Pagka-advance ang type 2 diabetes, meron ng beta cell dysfunction. Kaya pag mataas ang blood sugar, yung nawawala yung surge ng insulin, especially yung second phase ng insulin, nawawala yun eh. Yung first phase ng insulin release. Tumatas pa rin siguro yung insulin production pero dahan-dahan lang. Wala yung biglang taas ng insulin production na nag-i-inhibit ng alpha cell. Importante yun eh sa pag-inhibit ng alpha cell sa paggawa ng glucagon. Therefore, no, yung nananaig dapat na effect ng insulin nawawala. So, glucagon suppression does not occur just sa advanced type 2 diabetes. In the presence of high blood sugar, dumadami pa rin ang glucagon. Kaya, gawa pa rin siya ng gawa ng sugar. Malinaw po, ano? Malinaw yan, ha? Kwentuhan lang naman tayo eh. O, bago tayo, ngayon, pupunta naman tayo kung anong nangyayari pag mababa ang blood sugar sa isang individual na walang diabetes. Pag mababa ang blood sugar, bumababa ang production ng insulin. Kasi sugar ang greatest stimulant for insulin production. Kaya bababa ang insulin. At pag bumagsak ang insulin, mawawala ang suppression ng glucagon. Kaya gagawa ng glucagon ng alpha cell, kaya hindi nag-hypo yung mga walang diabetes. Pagka sinasabi nila nag-hypo sila, gutom lang sila, kumain sila. Pero hindi mag-hypo yan kasi ang galing ng alpha cell gumawa ng glucagon. Ngayon, ano nangyayari pag may advanced diabetes na merong beta cell dysfunction na? O, pag merong advanced type 2 diabetes at dysfunctional ang beta cell, pag bumagsak ang sugar nyo, individual, no, yung pagtaas ng insulin, nawawala eh. Nawawala yung, o yung pagbagsak ng insulin, rather, nawawala yung pagbagsak ng insulin. Kasi wala nang islet cell eh, na dysfunctional yung islet cell. No? Yung pagbagsak ng insulin na dapat mag-stimulate ng glucagon production kasi matatanggal ang suppression ng alpha cell, it disappears. Kaya nawawala din ang glucagon production pagka may advanced type 2 diabetes in response to hypoglycemia. Kaya mabilis silang mag-hypo. Hindi sila makarespond sa hypo gaano. Yan ang nangyayari pagka may dysfunctional beta cell sa type 2 diabetes. At ang interplay ng mga hormones na insulin sa alpha cell, ang tawag dyan ay paracrine effect. Paracrine kasi from one cell to another cell. Okay? Hindi yan endocrine. Endocrine from one cell to a distant cell. Yan, magkakatabing cells yan. Kaya paracrine effect yan. Yan ang pagkukwentuhan natin, pinagkwentuhan natin ngayon. Simple lang. Next time, iba naman ang pagkukwentuhan natin. Pero hopefully meron tayong naintindihan na konti. At kung meron kayong tanong, ay meron pa tayong 4 minutes. Ate Pat, may 4 minutes pa tayo.
Oo nga, meron tayong 4 minutes, Kuya.
O baka may tanong sila.
Ang naisip ko nga agad kanina, sana nung nagbabiochem tayo, nung first year medical student, ganyan kasimple ang turo, katulad ng, bakit ba dati ang hirap-hirap intindihin yan, no? Pero the way it was presented to us tonight by Kuya, no, parang ang dali-dali niya lang. Pero pag tayo ang nagbasa niyan, ilang chapter, ilang paragraph yan na babalik-balikan po, no, to understand that diagram na present ni Kuya kanina. So, tingnan natin kung meron tayong tanong galing sa ating mga members sa PSD. Mga kapatid, do you have any questions you would like to thank? Maraming nag-attend.
Kahit ano
Diyan sila
tanong,
Dr. Rima. So yung sa alpha cells, Kuya, so yung dysfunction niya, 'di ba, advanced stage ng dysfunction ng beta cell, meron na rin palang dysfunction sa alpha cell, 'di ba? Meron ba silang sinabing, nabanggit na time frame? Agad ba yan as soon as you are diagnosed? Yung probability na mag-hypo ka dahil may dysfunction na rin yung response mo because of the alpha cell dysfunction. Meron ba kayong nabasa how, is it parang sabay ba sila ni beta cell dysfunction? Parang nawala si Kuya or ako ang nawala. Ako ba nawala? Kuya, are you there?
Oh, in pa ba ako?
Ayan, nawala kayo, Kuya. Oo. Yung tanong ko,
naririnig niyo pa ba ako?
Apo, naririnig na po namin kayo ngayon.
Unstable yung internet ko.
Kaya nga, sige lang Kuya, 2 minuto ka na lang naman. Ang tanong, yung onset ng alpha cell dysfunction, kasabayan ba yon ni beta cell? Or sa advanced stage ni beta cell dysfunction, nagkakaroon ng alpha cell? I think unstable talaga si Kuya. We will just go on with our program. Tanungin na lang natin siya mamaya sa Q&A. So, as I have mentioned a while ago, this event is in partnership with our friends from Novo Nordisk. This is a CME grant. And for that, they have a lecture for tonight. And before we introduce the speaker, I would like to call on Ma'am Jackie Magpayo for some words for us, or maybe you have some announcement to make from Nova Nordisk.
Yes, thank you po, Dr. Fatma, and good evening, dear doctors. We would like to thank the Philippine Society of Diabetologists, most especially the Board of Directors, and of course, Dr. Elwin Fernando for this opportunity to partner with you in this select or PSD select po. So magandang gabi po sa inyong lahat. And as we know, 2021 po is an important milestone not only for Novo Nordisk but for the entire medical community because we are celebrating po the 100 years since insulin po was discovered. So allow us tonight po to highlight all the innovations that transpired during the century. So without further ado, I bring back the floor to Dr. Fatma Chu to introduce po our speaker for tonight. Salamat po, Dr. Fatma, and thank you everyone.
Thank you, Jackie. Thank you for your support always to us, especially to the Philippine Society of Diabetologists. So our speaker for tonight is somebody very much known to everyone. He is a senior faculty of the UERM Institute for Studies on Diabetes. He is the current president of ISDFI and the past president of the Philippine Society of Diabetologists. Let us all welcome Dr. Marcelo Lim. Kuya Eloy, good evening. There.
Good evening, friends and colleagues. Welcome to tonight's CME activity sponsored by Novo Nordisk. And in line with the 100 years of insulin innovation, I'll be focusing my presentation on the clinical impact of new generation insulin, focusing on insulin degludec, a steady and ready basal insulin. This is my disclosure. This CME medical education is sponsored by Novo Nordisk Pharmaceuticals Philippines Incorporated. Tonight, this would be the outline of my presentation. Being all students of diabetes, I will walk you through memory lanes, exploring the early experience with insulin therapy. Then moving on, we'll evaluate the advances in insulin innovations. And lastly, the focal point of my presentation, the need for the ideal basal insulin therapy using insulin degludec. It's been 100 years since the discovery of insulin. Time passes so quickly. And these are the key personalities that are responsible for the discovery of insulin. From left to right, we have an orthopedic surgeon, Frederick Banting. Then to his right, Charles Best, a medical student, University of Toronto. And then we have James Collip, a biochemist, a professor of biochemistry. And John James McLeod, head of physiology, University of Toronto. These are the 4 key personalities that are responsible for coming up with the life-saving insulin formulations, which had benefited a lot of the diabetic patients worldwide. So how does it all started? It all started in 1921 when Banting and Best performed experiments on dog pancreases. Eventually, with the help of Collip, a biochemist, they were able to produce a purified injectable extract from cow pancreas, and they called this insulin. After a series of improvement in their techniques and purification process, it was uh, commercially available as a manufactured product for use in the treatment of type 1 diabetes. Equally important personality aside from Banting and Best is Colip, who helped Banting and Best purify and administer the insulin extract to humans by developing a more effective extraction method. And lastly, McLeod, who provided the laboratory for Banting and Best to carry out their research and provided guidance for their experiments. Before the discovery of insulin, everyone that were afflicted with type 1 diabetes either died weeks or even years after the onset of diagnosis. With the discovery of insulin therapy, we have our first recipient. It's a 14-year-old boy with diabetes named Leonard Thompson, who was seen laying and dying from diabetes emergencies, ketoacidosis, urine full of acetone and sugar, with a ketotic breath, and weigh only 65 pounds. The first injection historically was given on January 11, 1922, wherein after the injection, blood sugar drops from 440 to 320 milligram. However, sad to say, inflammation at the injection sites due to allergic reaction was noted, leading to abscess formation. Thus, subsequent doses of insulin were not given. During this lull period of 12 days, Colip worked day and night to come up with a more purified extract. And fortunately, on the 12th day, the second injection, a cleaner, purer extract made by Colip was given on January 23, 1922. And this was a successful injection because there were no side effects that were noted, and there was complete elimination of glucosuria. This patient, this boy, this 14-year-old boy, Leonard Thompson, went on to have a relatively healthy life for another 13 years with regular insulin injections. However, at the age of 27, he died of pneumonia. During this time, there was still no cure for pneumonia. With the important discovery of insulin, the Nobel Prize for Physiology and Medicine was awarded to both McLeod and Banting. And Banting shared this recognition and this award with Charles Best, while McLeod shared this recognition with Colip. In the early years of insulin therapy, there were a lot of challenges, the growing up pains. Although insulin was able to reduce mortality rates, it was becoming evident they encountered a lot of high level of variability between batches, which make it difficult to determine proper doses and increase the risk of hypoglycemia. As was seen in the right side of the screen, you can see the wide glucose variability encountered during the early years of insulin therapy. This is from a personal account of Frederick Banting. When a single injection of insulin is given to a patient, there is a rapid fall of blood sugar. Sometimes the blood sugar falls well below the normal level. And this is accompanied by characteristic train of symptoms which we term as symptoms of hypoglycemia. So during the early years, during the time of Banting and Best, hypoglycemia seems to be the worst fear factor in the management of type 1 diabetic patients. It was felt that hypoglycemia constitutes a real source of danger. So there was a continuous process, innovations for a better pharmacological profile of insulin therapy. And so this lit up through the years, challenges were identified in managing type 2 diabetic patients with insulin therapy. And among the challenges, there are 4 key challenges that I would like to share with you. First and foremost is the inadequate glycemic control. This might be secondary to clinical inertia or suboptimal achievement of uh, glycemic control. Second would be the occurrence of hypoglycemia, which can be very costly and debilitating. You can also, the third key challenge is treatment complexity, the using of multiple insulin doses, and the using of more than one insulin formulation can make the treatment complex and reduce the adherence to treatment. And lastly, but very important, is the cost of diabetes treatment, especially more so in these challenging times during this COVID pandemic. So what is the key message here? In choosing for the right insulin therapy to be given to each and every patient of ours who required insulin therapy, it's just not merely efficacy, but an insulin that addresses the key challenges like lower risk for hypoglycemia, making the treatment simple and cost-effective. This would add values to the treatment. Now we run down through each of the key challenges. First, let's discuss about the inadequate glycemic control. We have been shown time and again these slides about the UK-PDS study, which show clear benefits of good blood glucose control. And every 1% drop in HbA1c can reduce long-term diabetes complications, more so the microvascular complications. And insulin had been time and again proven that it can give the optimum efficacy as far as lowering of the blood sugar is concerned. Second key challenges is the risk of hypoglycemia. The consequences of hypoglycemia present a considerable burden to patients and society. In fact, it could lead to unnecessary falls and fractures and accidents and lead to frequent hospitalization, which could be very costly in the management of diabetes. And insulin that can provide not only efficacy but lower risk of hypoglycemia would be most welcome. Also, the complexity of regimen is very, very vital for a success medical treatment of diabetes. Insulin should have a very simple regimen. While it's true that basal +1 or +2 or +3 would be very ideal in the management of diabetes, however, this is not prepared by most patients. And if we can only choose as an initiating insulin therapy, a simple regimen using only one pen and using only one shot a day might be a most welcome sight to our diabetic patients requiring insulin therapy. We should be reminded that more injections per year means more monitoring. So less injection, less monitoring. And if we can have an insulin that can have a simple regimen, that is again very welcome sight. Lastly, insulin should be very cost effective. A reasonable price that provides efficacy with lower risk of hypoglycemia, a simple regimen with less injections, convenience of flexibility in injection timing, meaning a true basal insulin with a long duration of action. So we now move on and discuss the clinical impact of new generation insulin, particularly focusing on the basal insulin that is available in the market. We continuously quest for the most ideal basal insulin. What do you want in our basal insulin? First and foremost, again, it should be efficacious. And we also strive for simplicity that can be given once daily with flexible dosing. We also value predictability of blood glucose lowering, a low glucose variability, and lower risk for hypoglycemia. So an ideal pharmacological profile of a good basal insulin should have a flat time action profile, meaning it's going to be peakless with a low glucose variability, lower risk for hypoglycemia, can exert its action for a full day coverage with a half-life of more than 24 hours. And of course, it should be potent to ensure good efficacy. So this slide shows the evolution of innovative insulin from 1922, the isolation of insulin by Banting and Best, to the 50s, animal insulin preparations, the bovine insulin, and then to 1977, recombinant human insulin. And in the 80s, saw the rise of the rapid-acting analogs, followed in the 1990s by basic analogs. And then in the 20s, you have the basal analogs, Detemir and Glargine. However, we are fortunate that we have seen some breakthrough in the past 10 years with the new generation analogs like insulin degludec, an ultra long-acting basal insulin with low glucose variability, with a lower risk for hypoglycemia. And then we have a new co-formulations, combination of insulin degludec and insulin aspart. Increased duration of action of basal insulin beyond 24 hours gave rise to insulin degludec. There was protein modifications on the B chain, and this led to a longer duration of action. Using other processes, combining insulin through co-formulations give rise to insulin degludec, insulin aspart. And the two insulin, even though they were combined, were able to retain their individual characteristics. Here is the insulin degludec molecule. It was rationally designed. It is similar to a human insulin. The only difference is there was a removal of the threonine at the B30, and then this was attached to a glutamic acid spacer on the B29, and there was an attachment of a 16-carbon fatty diacid side chain. So this gives rise to a new molecule biochemical structure of insulin degludec. So let's now go to some data showing the efficacy and safety of using insulin degludec. It has been extensively studied in the BEGIN clinical trial program, which involves more than 11,000 patients and over 257,000 patient years of exposure. The BEGIN clinical trial program on insulin degludec involves patients with type 1 diabetes, patients with type 2 diabetes, regardless of whether they are insulin naive or insulin experienced patients. So it was extensively studied. And what was the conclusion? In one of the studies, the BEGIN once long, comparing insulin degludec OD versus insulin glargine U100 once daily, they have shown to be equally similar in reducing the HbA1c and the fasting plasma glucose. So they're equally potent, successful reduction in HbA1c as with insulin glargine U100. This was based on the treat to target trials, and the fasting was significantly lower, and which this is where the basal insulin properly acts in lowering the basal hyperglycemia. So if you so what can we conclude from this study? Insulin degludec provides good glycemic control. Going further, insulin degludec had a long duration of action. It is a 24-hour peakless insulin formulation with a duration of action beyond 42 hours and a mean half-life of 25.4 hours, more than double that of the half-life of insulin glargine. As a matter of instructions, we always suggest to our patients that they inject their insulin at the exact time of the day to avoid omission of insulin injections. However, there are times that we are fully overloaded with our work and forget sometimes to give the exact time of injection, or we're watching a movie and forget about the insulin shots, or we're attending a very important occasions. And so on occasions like this, when administration at the same time of the day is not possible, insulin degludec allows for flexibility in the timing of insulin administration. So, pwedeng ibigay ang insulin kahit na hindi eksaktong oras, provided that there is a minimum dosing interval of 8 hours and a maximum interval of 40 hours that is properly observed. So definitely using insulin degludec allows flexibility in dosing whenever necessary. So aside from efficacy, if degludec affords patients once daily dosing with flexibility. So another good profile of the insulin degludec. Let's now move on to one of the common barrier of obtaining insulin target, of obtaining blood sugar target. The begin once long comparing insulin degludec OD versus insulin glargine U100. As far as confirmed hypoglycemia and nocturnal confirmed hypoglycemia is concerned, these were in favor of insulin degludec. For the confirmed hypoglycemia, there was a 16% numerical lower confirmed hypoglycemia in those patients receiving insulin degludec. And for the nocturnal confirmed hypoglycemia, there was a 43% statistically significant lowering of nocturnal confirmed hypoglycemia, again favoring those patients on insulin degludec. So this is very welcome, for we all know that though patients on insulin therapy face a higher risk for hypoglycemic episodes. However, in this comparative study, insulin degludec has lower rates of hypoglycemia. So summing up, insulin degludec seems to be an ideal basal insulin because it is efficacious. There was a successful A1C and fasting blood sugar reduction comparable with insulin glargine. It offers simplicity of regimen, more than 24 hours peakless duration of action with flexible dosing, a once daily dosing with 8 to 40 dosing interval allowed, and though similar risk for hypoglycemia with insulin glargine. However, findings have shown that there were lower rates of hypoglycemia in both confirmed and nocturnal hypoglycemia. So, to which patient can we use insulin glargine? Insulin degludec. Insulin degludec can be given to children aged 1 and above, adults and elderly with type 1 or type 2 diabetes, uncontrolled on OADs or other basal insulin, hypoglycemia with other basal insulin, you can shift to insulin degludec, multiple injections and lack of flexibility, which are common barriers to glycemic control, you can try the simple regimen of once a day insulin degludec. Patients with irregular lifestyle, patients with compromised hepatic and renal parameters. So these are the patients that you can use insulin degludec as an initiating insulin dose. However, you cannot use insulin degludec among pregnant patients and lactating patients, and those patients with an allergy to insulin degludec. So this is a very simple treatment algorithm on how to use insulin degludec. For insulin naive from OADs, you can add on a 10 units once daily insulin degludec. And if you're going to switch from a basal insulin, you can use the 1:1 ratio. If patient is receiving 15 units of another basal insulin, you can shift it to 15 units of insulin degludec. So it's a 1:1 total insulin dose ratio. And just following the simple treatment algorithm, if the above target, if the blood sugar is above target, you add 2 units. And if within target, you just maintain the dose. And if below the target, you subtract 2 units from the preceding dose. A once weekly titration is based on the average of 2 preceding fasting plasma glucose measurement. However, a word of caution, fasting plasma glucose target should always be individualized. You have to see if there are patients who have comorbidities, who have chronic kidney disease, wherein your target should be a little bit lower than the usual target. So just to summarize my presentation this afternoon, there are several factors to consider in deciding on the best glycemic management for type 2 diabetes patient. It is very important to incorporate patient-centered collaborative care. There are several potential barriers that may hinder optimal diabetes control. Thus, doctor and patient values should be aligned on the best treatment for the patient. Patients with type 2 diabetes may suffer from inadequate glycemic control, hypoglycemic events, treatment complexity, and cost of treatment. So these are the challenges. We are fortunate that we have insulin degludec now in the market, which provides successful glycemic control, simplicity in regimen, and reliable safety profile. Insulin degludec is an effective insulin that can be given in a broad range of patients in simple. I think that in conclusion, I would like to thank everyone for listening. And I hope that you have learned a lot from managing hyperglycemia. And again, to remind everyone, this symposium is made in the service of healthcare professionals by Novo Nordisk Philippines. And again, this is your friend, Dr. Marcelo Lim, changing diabetes one step at a time. Keep safe, everyone, and see you in our next event.
Thank you very much. Maraming salamat, Dr. Eloy Lim.
Good evening.
Thank you and congratulations, sir, for a clear and comprehensive presentation. It is very appropriate since we are celebrating the 100 years of insulin. And I'm sure our attendees tonight learn a lot, and we have here some questions for you. Andyan na ba si sir? Okay. Well, having been in practice a bit longer than some of our colleagues here this evening, who may not have experienced the time when there was only the human insulin available. Ako, naabutan ko na yung hirap na yun. And we didn't have all this modern, innovative insulin to choose from. So in your clinic practice, sir, how has the innovation of this new generation insulin improved how you treat your patients?
Well, first, I belong to another generation compared to you, Padma.
Hindi naman.
Noon, nakakaranas kami ng mga insulin allergy. Ewan ko lang kung naabutan mo yung mga ganong era. We had a few number of cases of insulin allergy because of impurities pa rin, mga contaminated zinc solution na nagkakaroon ng allergy. So now, we are very fortunate na meron tayong insulin na not only efficacious but safe, na low risk for hypoglycemia. If you're going to take the case of insulin degludec, a true long duration, ultra long duration basal insulin na lower rates of nocturnal and confirmed hypoglycemia at ang low glucose variability, at ang swerte pa ngayon is bumaba ang presyo, which is very cost effective. So with that, I think this will benefit a lot of our diabetic patients, both type 1 and type 2 diabetic patients.
We have another question, sir. Can we still give IDEG flexibly, since it's an ultra long acting, it has an ultra long acting profile? Pwede ba siyang ibigay at any time? Kunyari ngayon, tanghali, bukas, umaga naman, sa susunod na araw, gabi, basta mabigay lang siya ng once a day. Can we do that?
Well, meron tayong recommendation, no? As long as the interval is not shorter than 8 hours and not longer than 40 hours, pwede mong ibigay itong insulin degludec. Even it's ultra long acting, walang stacking phenomenon na nangyayari because it follow the first order kinetics. Kaya pwede mong ibigay yan sa mga pasyente who are busy with their lifestyle, trabaho, and other mga practitioners na gaya mo na very busy.
Okay, salamat. But we actually advise them, di ba, Kuya, to give it at certain time of the day for compliance lang, para alam lang nila na paggabi mag-inject sila.
Correct.
Or umaga. But if they miss their injection, they can actually inject it. Pwede nilang habulin for as long as it is not within the 8 hours of time. No?
Yes, tama yun.
Isang tanong pa, Kuya, how do you shift patients? Let's say naka-glargine, you mentioned a while ago, this long acting, ultra long, it has a better profile, less hypoglycemia. How do you shift your patients if you want to transfer them from glargine to degludec?
First, we usually do not shift na lang left and right ang mga insulin. If it's working at walang mga side effects, no, hindi re-retain natin. But in cases wherein your patient is experiencing hypoglycemia, and then you might want to opt for a newer formulation of basal insulin, pwede mong i-shift sa insulin degludec. You can shift it 1:1 ratio. Kung 10 units, 10 units then. 15 units, 15 units, and then you monitor and up-titrate.
Okay, and the titration was presented very clearly to us a while ago. So for the last question, and probably you can add more advice to our colleagues tonight, on what patient profile do you decide to start your IDEG as part?
Well,
Your
marami.
insulin
Marami,
degludec.
no? Alam na natin sa guidelines. No? Sino bang nangangailangan ng insulin? Marami. Number 1, yung mga pasyenteng naka-OADs but have suboptimal blood glucose control. we might want to add a basal insulin, like insulin degludec on top of the oral medication. And even in treatment na if patients who are cachectic, no, na with moderate to severe hyperglycemia, these patients might benefit from an insulin therapy with an orals, a combination therapy right away. Ang mga pasyenteng may renal and hepatic compromise, yun din, no? Mga ngailangan din ng insulin, which is a better choice than other oral medications. I think those are just some of the case scenario wherein you can use insulin therapy.
All right. I wanted to end there, but I think this one is an important question from Dr. Rafael Cruz. How do you convert if the patient is on intermediate human insulin to degludec?
Pwede rin naman, no? Anong intermediate acting insulin, for instance?
Wala siyang sinabi. So let's say naka 70-30 as intermediate lang. So siguro naka-N, no? 20 sa
Naka-N
umaga, 10 sa gabi.
O kung ginagamit niyo yun kasi, no, yung ang aking kasi dictum, if I shift from one formulation to another formulation, I usually go slow and start low. No? Kung naka 10 and 10 siya halimbawa, I might just pick up a dose in between ng 15 units and see how the patient will respond before up-titrating it. Madali lang kasi mag-up-titrate, no? Kasi minsan, iba yung potency kasi walang head-to-head analysis ng mga comparative data. But ako, I usually on the dictum, if I use another form of insulin therapy, I tend to go slow and start with a lower dose.
Okay, so start slow and go slow. So I think that's it. Thank you so much, our audience, for your active participation, and thank you, Dr. Eloy Lim, for answering our questions tonight. So we move on to the next part of our program, which is alpha cell in type 1 diabetes, that will be discussed by paborito natin ito, no? Paborito ko. Paborito nating lahat. He is one of the faculty of the Institute for Studies in Diabetes Foundation. Kasama ko siya sa Diabetes Philippines. He is currently our Secretary of the Board of Trustees. He is a fellow of the PCP and the Philippine Society of Diabetologists. Friends, colleagues, let's all welcome si Kuya Nines Bautista. Hello, Nines. Good evening.
Hello? Can you hear me now?
Yes, but you're a bit dark.
I'm a bit dark. Wait, I have to...
No, it's
there.
There. Yeah.
There. Okay.
Yes.
Anyway, thank you, Dr. Rafat. Thank you, Dr. Eloy, for that very good lecture on the newer generation insulin. First of all, I'd like to thank the PSD for giving me this opportunity to give some insights, no, to tell you what I have learned reading about alpha cell dysfunction in type 1 diabetes mellitus. Can you see my slides pala, Dr.
Yes.
Okay.
Yes, I can.
Okay. So the title of my talk is alpha cell dysfunction in type 1 diabetes mellitus. So I have 3 objectives for tonight. First, I'll be reviewing you the anatomy and pathophysiology of type 1, followed by learning what's the role of alpha cells. We always tell that the problem is really the beta cells. So how about the alpha cells? What is happening to the alpha cells in our type 1 diabetics? And we will be learning some new insights on the importance of alpha cell in type 1 diabetes and what's its clinical implication in our practice. So let us first review what does the pancreas look like. Okay, when you look at the section of the pancreas, okay, you see that there's an exocrine tissue that have your assigner cells. These are the one that secretes your trypsin, chymotrypsin. Those are for for digestion. And at the same time, we have what you call the pancreatic islets. And the pancreatic islets, we have five. No, we have your alpha cells, 10 to 20%, sometimes up to 40%. Your beta cells, 60 to 80%. Your pancreatic polypeptide, and your delta cells, 5%, and your epsilon that secretes your ghrelin. So let us now look at the comparison between a normal islet versus a type 1. This is a cartoon telling us that patients with type 1 diabetes, okay, you see that the beta cells are destroyed, but there is the presence of your alpha cells. We always talk about juxtaposition, Parkrin. Later, I'll be trying to review on what are really these things, okay, in hormone secretion of your glucagon. So this is an example of the endocrine pancreas of type 1 patients. Uh, in the brown one are your insulin, and the red one are your glucagon. And if you look at the anatomy of these beta cells, okay, these pancreatic islets, that the beta cell, you see that in type 1 patients, they are devoid of your insulin secreting cells that are your beta cells. Majority are color red, but you see that their size are almost the same. Okay, so this is a study by Bonnell and Serrano. They look at non-diabetic subjects versus those patients who are diabetic. Some of these patients, I think 8 were cadaver. No, some of them were organ donor. And then some of them were live. Okay, so if you look at this study, the male to female ratio 61, 39, 60, 40. They age 30. Okay, their BMI of 26 and 24 with an A1C which is normal in non-diabetic subjects, and patients who are type 1 have an A1C of 9.7. If you look at the HbA1c, okay, in millimole, it is elevated, and the pancreatic weight of non-diabetic subjects was more compared to that pancreatic weight of your type 1. And the disease duration of the type 1 is almost 19 years of age. So in this study, we have to look at what you call the beta and the alpha cells to total tissue area. So letter A is the beta cell to your total tissue area. This is a type 1 diabetic compared to your non-diabetic. You see that they are devoid of almost of your beta cells. Okay? In letter B, this is the beta cell mass. The beta cell mass is almost less, and these are your control subjects. Letter C is what happens to your alpha cells. In the alpha cells to your total tissue uh, uh, comparison, the ratio is almost the same. And your alpha cells in type 1 diabetic is almost the same. So it means that type 1 diabetic has what you call hyperplasia or sometimes hypertrophy of their beta cells. This is important. Later, I'll be discussing it. So let us review type 1 diabetes physiology. You all know this, that there is a beta cell destruction that will lead to your absolute insulin deficiency. And it is immune mediated. Some of them are idiopathic. Okay? So these slides just tells us that when a patient is non-diabetic, okay, the beta cell mass is high, and there will be an interaction of your susceptibility gene, your human leukocyte antigen, together with your environmental trigger. If that happens, if they have the preponderance for type 1, there will be an immune dysregulation. So the beta cell mass will go down, and during this time, there will be insulitis and injury to the beta cell. You can see here the presence of your insulin autoantibody, your GAD, your ICA, and there will be coming a time that there will be loss of the first phase of insulin release that will produce your overt diabetes, and your C-peptide will be below or beyond detection. Okay, so let us look at that one together with the classification. So when we classify, this is the stages of your type 1, characterized by autoimmunity in stage 1 and 2. There's normoglycemia. They are pre-symptomatic. What is important is you were able to look at the multiple autoantibodies. The blood glucose is still normal at this stage. And at stage 2, there's already dysglycemia. They're pre-symptomatic. They're the presence of multiple autoantibodies. And when you look at their blood glucose, they're at the pre-diabetic stage. And stage 3 are those patients with new onset hyperglycemia, sometimes producing diabetic ketoacidosis. Okay? So this is the classification. So why is this important? So this is another cartoon telling us on what we have discussed, that there is genetic susceptibility, there environmental trigger, and then there's an immune reaction, and then your beta cell will be destroyed. So there are no data on what is happening to the alpha cells. So how about the alpha cell? What is happening to it? So we will discuss that. Okay, and what is the clinical implication of what is happening to the beta cell? But before that, we have to remember some terms. Okay, so we need to know juxtaposition, paracrine, and bihormonal. I think I am the third lecturer that will be discussing juxtaposition, paracrine, and bihormonal secretion. Okay, so let us review the anatomy and physiology of the alpha cells. The alpha cells comprise 1% of the pancreatic volume and 30 to 40% of the pancreatic islet. Okay, they are the one that secrete glucagon. Okay, if you stain them, and the glucagon secreting alpha cell and and your insulin secreting beta cell share a common cell lineage but differ in their terminal differentiation into their characteristic cell types. Okay, so before I go on with my lecture, okay, we became medical students. So these are trivia on the contribution of medical students on the alpha cells. In 1869, Paul Langerhans identified an island of clear cells in the pancreas while he was a 22-year-old medical student. These were later named as the islets of Langerhans and are known to contain alpha cells. While in 1907, another medical student by the name of Michael Lane discovered that there were two distinct cell types in the islets, which he went on to term the alpha and the beta. So another day, we are commemorating the 100 years of insulin. Charles Best, together with Banting. Banting was a medical student, and he noted that the injection of crude canine pancreatic extract to diabetic dogs resulted in an early rise before subsequent hypoglycemia. And lastly, in 1923, it was Charles Kimball, a biochemistry student, isolated the substance from the alpha cells and named it glucagon. Despite such discovery, he never achieved his PhD in the University of Rochester. But those are just trivia. Okay, we have four students that had made in the field of diabetology. So this is a topographic scheme of a normal human islet. Okay, compared to a rat or a mice, as discussed by Dr. Elwin, the beta cell are at the core and the alpha cells are surrounded by it. Why is this topographic scheme of a normal islet very important? Okay, remember the term juxtaposition. Extensive juxtaposition of the beta cells to alpha cells facilitate the instantaneous insulin control of glucagon secretion via the interstitial space separating the two cells. So talagang magkadikit sila, pag mataas ang asukal, magsisecrete ng insulin. Pag yung glucagon bababa, okay? Pag mababa asukal, tataas yung glucagon, yung insulin bababa, okay? So that is the importance of the juxtaposition. And we will be discussing the paracrine effect later. Okay? This is a study by Unger and Orsi. They look at the islets. And when you look at a non-diabetic, there are presents, the red one are your alpha cells that secretes glucagon. The red one are your beta cells that secretes insulin. and the green one are your alpha cells. You see here that type 1 diabetic have a lot of alpha cells, but they don't have your beta cells because they are destroyed. Okay? And remember that the close proximity permits insulin to tightly regulate glucagon secretion and precisely control insulin to glucagon ratio in a healthy pancreatic islet. Kaya nga, nami-maintain natin yung normal na sugar kasi magkadikit yung dalawa. Pag alam niyang mataas, okay, ito yung ilalabas niya. Pag mababa, ito yung ilalabas niya. Okay? Pero dito, mapapansin mo, wala. Halos alpha cells ang nandyan. Okay? So what will happen to alpha cells if your type 1 have no beta cells? Okay? So this is the confocal microscopy of a normal islet. This is the demonstration of the reciprocal responses of insulin and glucagon to 20 milligram changes in the concentration of glucose. So if the blood glucose is elevated, you see that you will be secreting insulin. That is the first phase, followed by the second phase. And if there is high insulin, your glucagon will go down. Once the blood glucose is going down, your glucagon will go up to its normal level. So this confocal microscopy of a normal human islet shows that the extensive juxtaposition, yung magkadikit sila, okay, will regulate the normal glucose of our patients. Okay? So the question is the glucose regulation of the alpha cell an intrinsic or an autocrine effect or a paracrine effect? Okay? This is the switch off model. If the blood glucose is elevated, okay, your beta cell will be stimulated and will be releasing insulin, so glucose will go down. What happens to the beta cell if the blood glucose to the delta cell if the blood glucose is elevated? There will be stimulation of it, and your somatostatin will be released, and your glucagon won't be secreted kasi mataas ang asukal, so bababa ang yung glucagon. Okay? So yan ang major pathophysiology ng pagkakasama-sama ng tatlong cells na yan, no? So let us now look what happens to the alpha cell pag mababa ang asukal. This was discussed previously by Dr. Baldemore together with Dr. Ang. Okay? So if the blood glucose is low, your ATP-ADP ratio will go down. So there will be membrane depolarization, and this will open the potassium ATP channel in the alpha cells. So calcium will go inside, and there will be depolarization, sodium will go down, and your L and N type, okay, will stimulate again the entry of calcium. If there is calcium, okay, there will be a secretion of glucagon. Kaya pag mababa ang asukal, tataas ang glucagon because of this mechanism. Very important also, if there is glucagon, your glucagon can attach to the glucagon receptor and will activate your cyclic AMP together with the protein kinase A, and then calcium will be increased, and then there will be a release of glucagon kasi mababa. Okay? What is also important is about somatostatin. Okay? So, your delta cell secretes neurostatin. Ito yung NST. Your neurostatin will be attaching to its receptor, giving a positive feedback on your NF kappa B, increasing your protein kinase A, and a release of your glucagon. Okay? So, paano magkaiba ang iyong somatostatin 14 and your neuronostatin? Okay? Magkaiba sila sa amino acid sequence. Ito may disulfide linkage. Ito pinalitan niya ng amide. Okay? So, let us now look at the interaction between the three. Okay? This is your delta cell. This is your alpha cells, and this is your beta cells. Okay? Your delta cells can secrete your neurostatin. And your neurostatin, which will bind to your GPR receptor, that is your receptor for your neurostatin, and it will activate your NF-kappa and your protein kinase A, and it will be releasing glucagon. And your neurostatin, once it attaches to your GPR 107, will have an inhibitory effect on the beta cell. So your beta cell won't be secreting insulin. So yan ang interaction ng tatlo. These things happens in the alpha cells, okay, with your neurostatin. Okay? So this is another figure, okay, telling us, no, parang summary lang, pag mababa asukal, mababa ang glucose, mag-attach siya sa SLC2A receptor, okay? Bababa yung ADP mo, yung open mo yung potassium channel, T-type, papasok ang calcium, open mo yung sodium voltage gated, okay? Papasok yung calcium, lalabas ang iyong glucagon. So yan ang nangyayari pag mababa ang iyong asukal. So, what happens if your blood glucose is elevated? Okay? If your blood glucose is elevated, your glucose will be entering your beta cells and your alpha cells. Glucose enters your alpha cells, it will increase your ATP, closes that channel, closes the T, okay, calcium won't enter it, and there will be no secretion of glucagon. Okay? So, walang magsisikret. So, pag mataas naman ang asukal, your insulin will also be secreted. So, it will attach to its receptor in the alpha cells. Okay? There will be an increase in your phosphoinositol 3 kinase. Okay? And this will inhibit the release of your calcium and glucagon won't be secreted. Okay? Instead of the neurostatin, okay, your somatostatin will be attaching to this receptor, will give an inhibitory feedback to your cyclic AMP. Again, walang i-release na glucagon. So, magkakasama sila. Pag mataas ang asukal, eto lahat ang nangyayari. Merong mga neurotransmitter just like your GABA that can also play an important role. So, pag pinagsama-sama natin yan, okay, meron kang tinatawag na paracrine effect. Paracrine effect, magkadikit, okay, na mga cells, no, yung beta cells, alpha cells that are juxtaposed. So malalaman niya, malalaman natin kung maglalabas siya ng glucagon. Okay. So medyo guguluhin ko ng konti. Okay? So very important also, aside from your alpha cells and beta cells, because in the treatment later, no, pag diniscuss ni Dr. Ang, are your L cells, which secretes your GLP-1. Alam natin yan, no, with our lectures on your GLP. Okay, your K cells secretes your GIP. Your adipocytes, they are the one that secretes leptin, and they are inhibitory to your alpha cells. So tandaan nyo yan. And your myocytes also secretes interleukin 6. Okay? So, yan ang mga importante na kailangan nating malaman. So, type 1 diabetes and the alpha cells. Okay? So, alam natin kung ano nangyayari sa beta cells. So, sa alpha cells, in recent onset type 1 diabetes, histologically and pathologically, it is characterized by the lymphocytic infiltration of the islet. Okay? And histological-wise, if you analyze the pancreas in type 1, it shows specific beta cell loss. And there is preservation of the alpha cells and the other islet cells. And some reports, aside from the preservation, there is what you call mild alpha cell hyperplasia at the time of diagnosis. Okay? So, the loss of the beta cells in type 1 diabetes and the resulting loss of the insulin-mediated suppression of glucagon secretion dahil dun sa paracrine effect, okay, and may be expected to result in a persistently elevated levels of glucagon. So dahil wala na yung paracrine effect, mawawala na yung signal doon, tataas ang iyong glucagon. Kaya nga, nagbibigay na tayo ng insulin. Bakit tumataas pa yung blood glucose ng ating pasyente? Kasi there is what you call hyperglucagonemia. Tumataas yung glucagon. Okay? Whilst the absolute level of glucagon may not be consistently elevated, it is clear that these glucagon levels are higher than will be expected for hyperglycemia associated with type 1 diabetes. Okay? So, ito yung aking gustong malaman nyo. Okay? Isang slide lang to. This is by Yosten. Okay? Parang the natural history of type 1. what happens to the beta cells and the alpha cells. Okay? So, let us look at first the cell mass. Okay? So, these are the stages: pre-diabetic, overt diabetes, and advanced diabetes. Kasi dito natin malalaman bakit merong hypoglycemia unawareness, bakit dito meron hyperglycemia due to hyperglucagonemia. Okay? So, the beta cell mass is at this level and this is your alpha cell mass. Okay? Sabi natin, mas maraming beta cell, mas konti yung alpha cell, no? 40, dito nasa 30 to 40, ito hanggang 60. Okay? So, during the pre-diabetic stage, what happens to your hormone secretion of your insulin? So, sa type 1, meron ka pang initial secretion ng insulin. Meron ka pang secretion ng iyong alpha cells. Okay? Yung iyong stimulus secretion coupling, yung paracrine effect dahil magkadikit sila. Okay? Okay pa yon. So, once diabetic sets in, we call that overt diabetes. Okay? During overt diabetes, there will be a reduction in the beta cell mass and there will be an increase in your glucagon level. Tataas ang iyong glucagon. We call that hyperglucagonemia. Okay? And your beta cell will be secreting less insulin while your alpha cells will be releasing glucagon. Okay? And the stimulus secretion coupling nawawala. There's a loss of insulin-induced inhibition of the alpha cells. Nawawala yung connection dahil nasira na yung wala ka ng beta cell. So ang mangyayari, tataas ngayon ang iyong glucagon. Kaya kahit magbigay ka ng insulin, okay, kaya nga bihormonal yung i-discuss nating last term, okay, kahit magbigay ka ng insulin, meron pa ring glycemic volatility. Mataas pa rin asukal because of hyperglucagonemia. Okay? So, after 10 years, no, just like nung diniscuss ni Kuya, advanced diabetes in type 1, ang yung glucagon, this time, bababa na siya. Your alpha cell mass is almost the same. Ito yung iyong beta cell mass is almost the same. What happens is the loss of the alpha cell sensitivity to glucose. Hindi niya na alam na mababa na asukal. Mawawala na yung kanyang sensing mechanism. That is the stimulus secretion coupling. Kaya nga, dahil nawawala na yung sense na may mababa ang asukal, okay, patients have what you call hypoglycemia unawareness. Nawawala na yung mababa asukal, hindi nagsisikret ng glucagon, tapos wala silang nararamdaman during those times. Okay? So tandaan natin yon. So let us look those things in words para at least mas malinawan. Paulit-ulit ko yung slides na yun kasi very important yung slides na yon. So, in health, falling glucose triggers glucagon secretion, a phenomenon that is often absent in type 1. Okay? So, walang beta cell, okay? Meron kang alpha cells, okay? Pag mababa asukal dun sa latter stage, nawawala na yung phenomenon na yon. Furthermore, the loss of the beta cell function, the more blunted the glucagon increase with hypoglycemia. This blunted response increases the risk of hypoglycemia in patients with type 1 diabetes at the latter stage. Okay? Yung mga advanced type 1 diabetes. Okay? The reason for this yung first part naman, bakit tumataas yung glucagon? It is likely multifactorial, no? It has been proposed that the alpha cells need to sense a rise in insulin to decrease their glucagon secretion. And this rise will not be present in type 1 diabetes kasi nawala na nga yung paracrine effect. Okay? Puro ka lang alpha cells. Okay? The defect in both the glucose-dependent and the independent pathways controlling glucagon secretion may contribute to the hyperglycemia of type 1 diabetes in the first stage. Okay. So, alam na natin yung slides na yon. Ulitin ko uli yon kasi important yon. So, now let us look at the pathology of the alpha cells. Okay? As opposed to the beta cells, a component of your endocrine pancreas, which declines in number and total mass as type 1 progresses, dun sa slide na pinakita ko, alpha cells have been shown in humans and in multiple rodent models, including non-obese diabetic mice and streptozotocin treated mice and rats to be hypertrophic and hyperplastic. So dahil may hypertrophy sila, may hyperplasia sila, tumataas yung iyong glucagon. Hyperglucagonemia. Okay? Type 1 is characterized by a selective loss of the beta cell mass and insulin secretion which play an important role in the eventual resultant hyperglycemia. And multiple evidence championed by Unger and colleagues that glucagon hypersecretion is the major culprit in type 1 associated hyperglycemia. Okay, this was discussed by Dr. Ernie. Indeed, disruption of the glucagon receptor signaling via knocking out the global knockout mice GLP receptor prevented the metabolic derangement in type 1 diabetes that were treated with streptozotocin treated mice. So, a simpler explanation of alpha cells and or hypertrophy and hyperplasia could lie in the loss of insulin-mediated inhibition of the alpha cell secretory activity, eventually leading to alpha cell expansion and ultimately leading to glucagonemia. So, now we go on to the natural, we will be discussing also the natural history. Okay? So we have discussed hyperglucogonemia. We have discussed the impaired counter-regulation. That has a clinical implication in our practice. So there is a changing dogma of diabetes. In 1922, okay, it is insulinotropic. The lack of insulin directly causes all diabetes abnormalities. And in 1975, it was the term bihormonal, no? The different diabetes abnormalities are caused by the lack of insulin, okay, or an excess of glucagon, okay? Kaya nga bihormonal. And in 2011, there is what you call the glucagonocentric, okay? The lack of insulin directly causes some diabetic abnormalities. Insulin lack also leads to glucagon excess and in turn causes other symptoms. Okay. So, the alpha cells and type 1 diabetes. In type 1 diabetes, islets are devoid of beta cells and again, they tend to be hyperplastic. In contrast to the normal one, which are restrained by high local concentration of intra-islet insulin type 1 that are unregulated, this will produce again, no, ulit-ulit, hyperglucogonemia. Okay? And with no insulin to oppose the hepatic actions of hypergluconemia in type 1, unrestrained glycogenolysis, gluconeogenesis, ketogenesis, and hypercatabolism leads to ketoacidosis, cachexia, coma, and death. Okay? So, again, ito yon. So, you have to know this by heart. Okay? So, there's what you call cell mass, okay? Hormone secretion, stimulus secretion coupling, okay? Loss of insulin-induced inhibition, there will be hyperglucogonemia, okay? And in the advanced stage, the loss of alpha cells to sense glucose. That is your hypoglycemia unawareness that can happen to your patients. So, again, hyperglucogonemia can exacerbate hyperglycemia. Okay, as in type 2, patients with type 1 tend to exhibit hypergluconemia in spite of high blood glucose level. And Unger and colleagues propose that this paradoxical increase in glucagon release is the driving factor underlying hyperglycemia in type 1 and type 2. So, ngayon pupunta tayo sa mga figures naman, mga medyo, ito, explain natin. This is the study by Roger Unger. So, it is an experiment to hypoinsulinemic alloxan diabetic dogs. So, yung mga aso, okay, yung kanilang insulin, binabaan nila. So, what happens when they gave glucose at 8 mg per kilogram per minute? So, there is an increase in glucose without an increase in insulin, there be hyperglucogonemia. Dahil nga dun sa paracrine effect na dinidiscuss natin, hindi niya nasisense yun. So, dahil hindi niya nasisense, okay, tumataas ang glucagon level. Okay? So, failure of the counter-regulatory response. Okay? Patients with diabetes experience multiple hypoglycemic events with low glucose or have an increase in diabetes duration, particularly more than 10 years, are susceptible to a condition known as hypoglycemia unawareness. Okay, the numerous potential mechanism that could underline the failure of counter-regulation is the aberrant glucose transport ionic channel, as well as the loss of the paracrine signaling or the inability to respond to the paracrine signal. Okay, so alpha cell dysfunction in type 1 is complex. It's a complex phenomenon that changes over the course of the disease, okay, that can impact glucose homeostasis even in patients wherein we intensively give insulin. The physiological consequence of alpha cell dysfunction, okay, include both propensity for hyperglycemia and paradoxical hyperglycemia, just like that study by Unger, okay, producing postprandial hyperglucagonemia and insufficient glucagon release, resulting in hypoglycemia and hypoglycemia unawareness. So these are the mechanism for that. The functional and physical alpha cell hypertrophy and hyperplasia, as well the disinhibition of alpha cells due to the loss of influence of insulin. I think the relative resistance of alpha cells to glucotoxicity, lipotoxicity, and inflammatory cytokines, this will be discussed sa type 2. Ito yung tinatawag na alpha cells resistance. And the concentration of the response of the curve of glucose and alpha cells tends to be a bell shape. Okay? If there is very high glucose concentration, there will be an increase in glucagon. Compared dun sa mababa, okay, this will stimulate glucagon secretion. Sa moderate high glucose, it will inhibit glucagon secretion. And lastly, is the change in the ion channel expression, okay, of the alpha cells, in particular, the glucose transporters. So, ano naman yung potential mechanism of the counter-regulation, yung latter part, okay? The aberrant glucose transport or ion activity, as well as the paracrine signaling or the inability to respond to the paracrine signal. Also, there's a decrease in expression of your glucagon receptor in the alpha cells, such as the glucagon receptor and the neurostatin that I was talking to, your GPR107, could desensitize the alpha cells to produce the positive secretory signals. Okay? So, uh, this has been discussed eloquently by Dr. Ang. No? This is the confocal microscopy. Okay? This is after a meal since type 1, wala silang insulin. There's hyperglucagonemia. Okay? There's basal hyperglucagonemia and an increase in paradoxical glucagon post-pill. And even in subjects with optimally controlled type 1, exhibit this severe glycemic volatility because of hyperglucagonemia. So tumataas yung glucagon, kahit magbigay ka ng insulin, merong times pa rin na nag-hyperglycemia sila. So this was also discussed by Dr. Ang, no? Importante kasi to, no? Because of the paracrine signaling. Okay, with the 2,000, 4,000 micromole of your insulin that is secreted, pupunta siya sa splanchnic circulation, 600 na lang, and it will go to the systemic circulation and pupunta sa muscle yung 5 to 20. So, ano ang nangyayari pag mag-inject tayo ng insulin sa type 1? So, dahil wala na silang beta cells, meron lang silang alpha cells. Pag nag-inject tayo ng insulin, kay hindi na siya pumupunta dito, walang signal dito, kaya magre-release siya ng glucagon, okay? And dun sa ating peripheral tissue, pag nag-inject ka ng maraming insulin, it will produce hypoglycemia. Okay? Dahil may hypoglycemia ka, maglalabas pa rin ng maraming glucagon dito kasi wala yung paracrine signaling. So, there is hyperglucagonemia, thereby exacerbating your hyperglycemia in your type 1 diabetics. So, these are just the comparison of the acutely endogenous and injected. So, this is the secreted and the injected varies. No? I think this was discussed. So, ano kaya ang gagawin para ma-restore yung normal glycemic stability? No? Diniscuss natin, normally, merong alpha cell, may beta cell, merong liver. This is the splanchnic circulation. These are your target organ, no? The muscle cell and the adipose tissue. Meron kang 2,000 na secrete na insulin, Okay, bababa na siya and then ito na lang yung pupunta dito. Okay, your glucagon is at 50 picogram. So, pag meron kang exogenous insulin, nag-inject ka ng insulin dito. Okay? So, 20 yung iyong ibibigay. 20 lang from dito, pupunta sa liver, pupunta dito, pero meron kang hyperglucogonemia. So, what will you do para at least maging kaparehas nito? Okay? So, bababa or yung iyong glucagon, bababa. From 150, magiging 50 na lang. You inject a glucagon suppressor. You inject low-dose insulin para ang iyong insulin mababa na, meron kang mababang glucagon, and that is a therapeutic option just like giving your leptin to rat and mice. Okay? So, this is the Sherrington model. Okay? You remember the Sherrington model? Usually, that is the second law. If you contract your biceps, your triceps will relax. Okay? Ito rin yan. If there's high blood glucose, there's secretion of insulin, meron kang inhibition of glucagon, bababa ang iyong glucagon, your insulin will go to the systemic circulation, and there's an increase in peripheral glucose uptake. Okay? So, what happens if you give an insulin at the same time a glucagon suppression? Just like what has been discussed, a low-dose insulin together with your glucagon suppressor, okay, dahil sa type 1 diabetes, wala ng insulin, that will reduce what you call your glycemic or glucose volatility. Okay, so what are the proof of concept? This was discussed by Dr. Ernie Ang. Okay, if you give insulin monotherapy, matataas ang iyong dose, okay, ng iyong glucose kahit nagbibigay ka ng insulin. Pero pag binigyan mo ng leptin, okay, bababa ang asukal. So, insulin therapy is sufficient for type 1 diabetes. This is the classic dogma. Okay? So, again, this was discussed by Dr. Ang that insulin replacement alone is not a complete therapy for type 1. Okay? So, because there is hyperglucogonemia, okay, thereby producing what you call your glycemic volatility in your type 1 compared to your non-diabetic counterpart. So, how to stabilize? You give a low-dose insulin and leptin, your glucagon suppressor, then that will reduce the blood glucose. If you give glucagon at 200 microgram, okay, you give a glucagon suppressor, bababa. So, this is a study by Yang Li. They concluded that blocking the glucagon action prevents the deadly metabolic and clinical derangement of type 1, although, again, this is in mice. Okay? So, ito yung sinasabi natin. You give a low dose of insulin and a glucagon suppressor, then in mice, okay, you stabilize the blood glucose of your patient. Bababa siya. Okay, another, okay, sabi natin kanina, this is the bihormonal treatment. You treat with insulin and you treat with glucagon. Okay, this time, they're giving anti-glucagon suppression, they're giving your leptin infusion. So, this is a study in rodents on leptin. This is your optimal insulin alone. But if you suppress glucagon, giving your leptin, bababa. So, these are the three desirable effects of leptin. A reduction in tissue content and plasma concentration. Galing yan sa adipose tissue, di ba? Okay? Of your triacylglycerol and free fatty acids. I think this was discussed by Dr. Dan. The body fat was reduced well below the level of insulin monotherapy and the lean body mass was increased. These changes were expected to increase insulin sensitivity. If you downregulate the expression of your cholesterol-logenic transcription SREBP, okay, methyl-glucuryl co-reductase, the rate limiting step of your cholesterol synthesis, that changes will reduce coronary artery disease in type 1 diabetes. Okay? And a reduction in appetite, okay, that would greatly facilitate compliance with dietary restriction, play a vital role if you give leptin to diabetic mice. Okay? So again, this is the natural history of the alpha cell. Okay? So malapit na. So what are the clinical implications of to all of those things? Glucagon secretion is controlled by glucose plus a network of hormones and plays a crucial role in the regulation of glucose. And your GLP, I think this will be discussed at the last part, your DPP-4 and amylin analogs modulate glucagon levels, have therapeutic potential in type 1. Novel agents are in development that directly influence your glucagon receptor signaling. And the therapeutic strategies, emerging therapies that are designed to regulate glucose, such as beta cell replacement and the closed loop pancreas system, as well as the glucagon receptor antagonists, okay, are promising technologies that eventually mitigate hyperglycemia and hypoglycemia associated with alpha cell dysfunction in type 1 diabetes. However, new therapeutic strategies must be developed to bridge that gap and hopefully prevent the aberrant glucagon hypersecretion in type 1. Remember that insulin replacement therapy, again, this is our concepts, okay, according to Unger, Anofi, okay, normal glucose regulation involves multiple hormones, insulin, glucagon, incretin, amylin, and multiple organ system. Insulin replacement does not fully mimic the action of insulin secreted by the pancreas on healthy individuals. And insulin exposure in the liver is lower with replacement therapy than with the natural production, resulting in inadequate suppression of your glucose production. Again, that is your paracrine effect. And higher doses of insulin are required to achieve kasi hindi na pumupunta dun sa taas, okay? Dun sa beta cells, uh, uh, there will be suppression of your endogenous glucose production, but these changes will be associated with hypoglycemia and weight gain in our type 1. And conventional insulin treatment corrects the endocrine insulin deficiency, but does not fully correct the paracrine insulin deficiency, in which there's a contribution of your alpha cells in glycemic volatility in type 1 diabetes. So, just recap, okay? For the clinical implication, amylin is deficient in type 1 diabetic patients. Okay? These are type 1 and no type 1. So amylin is deficient. So if you give amylin in the States, it's available. That's pramlintide. Okay? It slows gastric emptying. It promotes satiety and reduces caloric intake. And it inhibits inappropriate the high postprandial glucagon. So if you use your pramlintide, okay, in your type 1, okay, it is approved in the United States. It will delay emptying of the stomach and inhibit glucagon secretion. It has been shown to reduce A1C, promote weight, and lower down the dose of insulin. And the common side effects are nausea, vomiting, and hypoglycemia. These are just study comparing pramlintide versus placebo. There's a reduction. This is placebo plus insulin, pramlintide plus insulin. So you see that there's a reduction in A1C, okay, and a reduction in weight. So those patients who have an A1C of 8.1, their A1C went down to 7.6. So these are just trials on amylin. Okay? Di-discuss na lang yan on the latter part. Okay? Your GLP, again, they are use of label in type 1. You all know this, that your GLP slows gastric emptying in the stomach. Okay? They stimulate insulin secretion and their suppression of your glucagon. Okay? So if you give liraglutide versus placebo in type 1 diabetes, there's a reduction in your A1C and a reduction in weight. This is a study with your exenatide. And these are ongoing trial. Okay? So, how about your DPP-4? Remember, your GLP are degraded by your DPP-4. So, you inhibit this, tataas yung iyong GLP that will stimulate insulin secretion and suppress glucagon secretion. So, if that happens, okay, bababa asukal. So, in type 1, this is a study comparing placebo versus those given sitagliptin. So, at the end of 16 weeks, there was a reduction. Okay? So, a study using saxagliptin in patients with LADA, with vildagliptin, another study, and these are the trials, okay, for type 1 using your DPP-4. So, I look at two studies. This is the counter-regulatory hormone response to hypoglycemia in people with type 1 after treatment of your liraglutide as an adjunct to insulin. So tinitingnan nila dito, bigyan kaya natin ng liraglutide yung type 1, ano kaya ang mangyayari dun sa mga counter-regulatory hormone response. So in this study, liraglutide did not compromise hypoglycemia response in patients with type 1 at the end of 4 weeks. And a study, the efficacy and safety of your liraglutide as an adjunct to your insulin. So they concluded that when you add liraglutide to insulin, okay, the total insulin dose, the body weight was generally, which was generally representative of the type 1 diabetic subjects, okay, there's an increased rates of hypoglycemia and hyperglycemic with ketosis, thereby, again, using liraglutide, limiting the clinical use of this one. I think that is my last slide. Salamat po. I hope you...
Congratulations. Galing-galing ni Nines. Congratulations. Very impressive presentation, Nines. I think maraming medyo hindi pa nakukuha siya lahat, no? But it was very powerful presentation. It was very clear. Na-discuss mo yung mga ibang regulatory hormones for glucose control. Lagi kasi tayo nasa beta cell, no? So pagka nagagamot tayo, niisip lang natin ang beta cell, and ang alpha cell hindi na pag-uusapan. And now we see how very important, as it comprises about 30%, tama ba, Nines, ng ating pancreatic pancreatic cells. So a derangement in the 30% of the pancreatic function is definitely very important and has a big impact on our patients' metabolic control. So what can you say about drugs that will act on the alpha cells? Sabi mo na nga kanina, yung mga studies. So hypothetically, it might work, no?
Yeah.
So, but right now, we're not really using it, modulating the alpha cells in our type 1 diabetes. Can you say something more? Baka in the next ilang years, iba na ang takbo ng usapan pagdating sa type 1.
Yeah, I think Professor Ang will discuss that in the implication of clinical practice. But remember, these are mice model, and I just saw two studies about your GLP. Okay? So yung GLP natin, no, just like liraglutide, so again, in type 1, it's still insulin. So yun pa rin. So yung mga glucagon suppressor, okay, leptin, okay, they're still under development. So maybe because of the side effect. Importante talaga, dapat nandun yung paracrine effect, the autocrine effect, nagkadikit-dikan, juxtaposition. Pag nagka-leche-leche yan, okay, talagang magugulo. Kaya talagang medyo tayo, maybe in the future, with yung yung tinatawag na bionic pancreas, merong glucagon, may ano, baka yan ang mag-bridge ng gap in the future.
So right now, we are still in the insulin treatment, no, for our type 1 diabetes. Pero kahit naman yung mga GLP-1 na yan, nung nag-aaral kami, nung unang nilabas yan, parang hindi mo rin naman sila ma-imagine how they can be translated into actual treatment. So baka in the future, no, babalansihin mo talaga yung pag-treat mo ng insulin at pag-treat mo ng yung mga alpha cells. So I think we have some questions from the audience.
Yan, kay Dr. Cynthia, meron yata yan.
Dr. Cynthia, may I know po, Dr. Nines, how do we usually observe the progression from pre-diabetes to diabetes stage among type 1 diabetic patients? How long po do we usually observe this?
Okay,
How do
anyway,
we observe it? Long. Yung
yung
pre-diabetes type
oo.
1.
Kasi ang problem with type 1 diabetes, we usually see them once they have symptoms. They're already at the latter part, overt diabetic na sila. Okay? Maybe if we look at the human leukocyte antigen, if they are if they have those genes that can promote beta cell dysfunction together with the triggering environment, and then we measure your autoantibody, pwede nating malaman. Okay, I really don't know. Basta importante, when 80% of the beta cell ang namatay, okay, dun tayo nagkakaroon ng overt, dun na nagkaka-DKA. Okay? So, siguro there will be studies on those. Okay, pero tayo clinically nandun na sa latter part. Nasa latter part na kasi tayo, nandun na yung ano. Pero dun sa pre-diabetic stage up to the diabetic stage, it depends upon the autoimmune destruction and the beta cell decline.
How long ang estimate, how long ang usual pre-diabetic stage? Did you come to any data telling us bago nagka-diabetes siya, may pre-diabetic stage ba sa stage sa type 1?
Sa
Is there
type 2
such a
kasi, di
thing?
ba, meron, di ba? Pero sa type 1, I have to answer that in the next kwentuhan. Maybe I have to look how long. I have no idea how long. But I have to look at, kasi nandun na tayo lagi. But there are studies, no? Meron ng autoantibody, tinitingnan nila. But they're giving drugs, just nagbibigay ng insulin, okay? Nagbibigay ng iba-ibang suppressor para hindi magka-type 1, yung TEDdy study. So I will answer that in the next, kung how long talaga yung pre-diabetic. I haven't read how long really. So maybe I'll answer that. I promise. In next Saturday session, I'll look the answer for that. I have no definite answer because I really don't know how long. Okay, but
Yeah.
that is just the hypothetical story. But in type 2, alam naman natin, when the beta cell dysfunction is 80%, okay, and there's lipotoxicity, doon natin ma-estimate natin kung how long from pre-diabetic. And if you, in your type 2 diabetic, if you do lifestyle, then mababagalan. But in type 1, it's different. Kaya nga, I really don't know. Maybe type 2, from pre-diabetic to diabetic, malalaman natin. Pero yung type 2, type 1, I really don't know.
Tsaka pag may mga test siguro that can look into yung mga proglucagon gene na may measure na yung mga ganon, no? Yung ganon ka-early, yung mga GLP-1, baka sakaling mas mapipredict mo, no? But other than that, yung mga C-peptide kaya makatulong. Pero usually, hindi mo naman natin ginagawa yan.
Si Dr. Grace daw
Anyway,
mag-a-answer. Bago yung kay Dr.
Mama
Rino.
Grace, yes.
Yan.
Nasagot niya ang ating
Baka ma-access niya yung tanong, Mama Grace, ako di ko alam how long.
Mama Grace. Ano po ang inyong zoom in natin si Mama Grace. Paki-unmute si Mama Grace. Sa kwentuhan, kung hindi maipasok si Mama Grace, we will...
Okay na. Ang
Ayan na,
ano,
okay.
yung habang pag normal pa yung blood sugar ng isang pre-diabetes hindi natin tatawagin pre-diabetes, pero meron na siyang mga antibodies, ganon, hindi pa masyadong sira yung kanyang beta cells, pwede ka mag-measure ng C-peptides. Okay? Para malaman mo kung gaano kasira na yung kanyang beta cells. And then, the degree how fast it will deteriorate will depends upon the degree of the process of the immune reaction. So yung very fast or very slow ang kanyang progression will depend on the degree of the immune reaction of the body. So well, hindi mahirap sabihin kung how long talaga. So depende sa tao.
All right.
Thank you, Mama Grace.
So
Meron question si Dr. Sales.
Ganda na lecture mo.
Oo. Naka-tape po ito. So for those of you who would like to, kasi syempre pag pathophysiology, maganda siyang balikan, pakinggan ulit, para mas matandaan natin. Naka-tape po itong session natin and we will be loading it. We will be giving you the link dun sa ating chat group. So I think it's 7:40 and we had a very interesting interaction with our speakers. Dr. Nines Bautista, maraming salamat. And if you have questions for Dr. Nines, pwede niyong ipadala sa atin and then doon na lang uli sa kwentuhan natin i-resolve yung mga issues katulad nung mga nakaraang sessions. So again, thank you everyone for attending tonight's event. See you all again on March 27, 2021 for the episode 4 of our PSD Select series. Good night and enjoy your dinner with your family. Be
Thank
safe,
you.
everyone. Bye.